right. So, welcome, everybody. It's great to see you all again, as always. And this month in our developmental disability clinical and research rounds, we have a presentation by Dr. Anna Sulimarti on epilepsy. And I think we're really fortunate. Dr. Sulimarti is great at what she does. Parents and patients speak really, really highly of her. And so I have a couple of trainees who've worked with me. And so I think we're really fortunate to have her with us today. So interestingly, Dr. Sulimarti completed 1 year of veterinary school before starting medical school, and eventually completed her medical school at the University of Valencia in Spain. She then moved to Zaragoza in Spain at the Zaragoza University and completed her neurology residency before completing a fellowship in headache at the University of Valencia and a fellowship in EEG and epilepsy here in London at Western University. Dr. Sulimarti also has a master's degree in medical research from Zaragoza University and also a PhD in medicine at the University of Valencia. So it's done a lot of training and has really a lot of expertise. Anna joined the faculty in the School of Medicine at Western University in 2018 and is currently an associate professor in the Department of Clinical Neurological Sciences at Western and is also co-chair of the Western Epilepsy Research Group. Dr. Sulimarti's track record for publications and grant funding is remarkable at this point. So she's published over or about 65 papers as author or co-author, and almost 150 abstracts of her work have been presented at various conferences internationally. And with colleagues, Dr. Sulimarti has held or holds well over $6.6 million in grant funding. So a huge amount, which is great, and obviously does a lot of research. Today, Dr. Sulimarti is going to talk about overcoming barriers, managing drug-resistant epileptic syndromes. And for one, I'm really looking forward to the talk. So, Anna, thank you very much for joining us.
Yeah, it's a pleasure to be here, and I hope that this presentation could be helpful and not too boring to many of you. Again, we'll be focusing in epilepsy and epileptic syndrome. So moving forward, I have some disclosures that I have been part of the consulting fees and grants from different pharma companies, but again, they are unrelated to the talk today. And then what I divide the talk is in three parts. Of course, the first part is recognize the most common drug-resistant epilepsy syndromes across the lifespan. I hope to describe the most relevant clinical features of the most common syndromes like Lennox, Gastaut, Dravet, or tuberous sclerosis complex. And at the end, just briefly touch about the current and emerging therapies for patients with drug-resistant epilepsy. So again, syndrome, as you know, an epileptic syndrome is a set of clinical EEG, etiological, and evolutionary features that occur consistently in a group of people with epilepsy. And this could be related to the age of onset, type of seizures, EEG, imaging, response to treatment, or prognosis or comorbidities. And this is significant, not just to put a label, but also will imply how we can accurately treat those patients. We can also discuss with the patients and the families the prognosis, and of course identify some genetic or even structural cause that can justify the syndrome or the presentation that we are seeing in our patients. So how we have been classifying the syndromes. Again, you probably hear that in epilepsy, we love to reclassify, rename syndromes, seizure types. So in 2022, a group of epileptologists decided we are going to change names and how we label this. So they grouped the epilepsy syndromes in different categories, and they divide it according to the age. They divide in neonates or infants up to 2 years, childhood initiation syndromes, and then with variable age, and there is a big group of generalized idiopathic epilepsy. And other ways to subclassify is if they have generalized, focal, or the combination of both. And also they introduce the concept of developmental syndromes and epileptic encephalopathies or DEs, or with progressive neurological impairment that has been growing the interest of the scientific community. So this is kind of the scheme of how they divide the syndromes. Again, there is no time in this hour to go over all this, but at least to have a strong general concept about some of those syndromes and at least understand if it's not normal what we are seeing. So if we start with the first one, childhood or neonatal syndrome, it's up to the age of 2, and the incidence is high and frequently associated with comorbidities and mortality. So it's a very delicate period of time, and if the baby starts with seizure, it's not a good sign. as 54% of these epilepsies that start below the age of 3, they are related to syndromes. If you compare with older kids, that's significantly less. And in the opposite side, like below 12 years, 64, we can have a clear etiology. And they divide these in the ones that they have spontaneous remissions and the ones that they are, again, developmental and epileptic encephalopathies with even worse prognosis. So a bit more about these early stages. The incidence is age dependent. Is the incidence, again, there are two peaks in epilepsy very early on, as I say, below the age of 5 years, and this is comparable to over 65. So in babies, we have more syndromes, and in elderly, we have more other secondary causes like strokes, tumors, injuries, and that goes over 60 over 100,000. This also, if we compare the first year versus slightly older, you can see 82.1 to 118 versus 46 over 100,000. Again, the older, the less incidence. And then in newborns at 6 months, again, making kind of clear the number, 75 over 100,000 compared to even over 6 months, it's 62. So it just it goes down over time. But the other main concept that we need to understand of these early stages is the cognitive and behavioral comorbidities that we will see in those patients. Also, the earlier they start with seizures, the harder it will be to control. 50% will show a global developmental delay, even 2 years after presentation, and higher the risk, and this is interrelated, more delay, more drug resistant, more comorbidities. And then a new area that has been growing over the last 20 years, but especially in the last 10 years, is the genetics, and many different genes have been identified. And these CDKL5, STAXBP1, for example, are growing the interest and the relation with these syndromes. This is from this first age group. One of the types was the self-limiting epileptic syndrome. So this is not considered a benign, but it's supposed to be self-limited. Usually start below the age of 2 and usually responds to anti-seizure medication. And this group, a difference to many of them, will have normal or near normal cognition, and it usually is associated with some genetic or pathogenic variants. In the table in yellow, you can see the different names of the different syndromes that, again, I don't have time to go over all of them, but it's just to have an understanding of them. The other big group is the developmental and epileptic encephalopathies that, a difference to the other one, these ones are more severe. They have comorbidities, neurodevelopmental comorbidities. Usually you could identify a cause, not always. And it could be the early age, below 3 months, or other DEs that happens after 3 months, but below the age of 2. And again, here you can see the different type of developmental epileptic encephalopathies in this group. And one of them is the Dravet syndrome, that I'm going to explain a bit more because it's, as rare it is, it's relatively frequent or more common. So it starts also in neonatal period up to 2 years, affects approximately 2.5 to 6.5 over 100,000 live births, and boys are slightly more affected than girls. And 3% of all the cases of children with seizures during the first year of life. So it's relatively small, the percentage, but it's very relevant to be aware of this. And also it has shown the relation with if they start with seizures in the first year of life after vaccination. What is important with Dravet syndrome is that, as I mentioned, genetics has been growing, and CN1A mutation is causing 80% of the cases of Dravet. However, not all the patients who have CN1A have Dravet. So again, 90% of these mutations are de novo, and the ones that we identify as potentially de novo, 10% of those ones, they have parents with mosaicism in the same gene, or there is a family history of febrile seizure, other type of epilepsies in 30 to 50% of those cases with Dravet. The phenotype of this of Dravet is it's in parallel with the presentation of this abnormal gene that is a channelopathy. And there are two variants that they have been identified, at least, that are more remarkable, including the nonsense pathogenic variant in the voltage sensor or pore region that has more severe prognostic, and also the pore forming region and truncation can be associated with more severe gait alterations. So the a bit of how it's presented, as I say, start very early on, usually 3 to 9 months. It could be below, it could be around 1 year to 20, but 3 to 9 is the most typical time of presenting, and usually are prolonged febrile or no febrile focal seizure, usually as a myoclonic seizure, generalized clonic seizures, and is frequently associated with fever or or like hot days or immunization. Initially, it could be think that this is febrile seizures, but then when it repeats, perhaps without a clear fever, or the hemiclonic is very typical from Dravet, that it will be just a typical febrile seizure, should be more a generalized tonic-clonic. And between 0 to 5, of course, there is some status epilepticus, as I say, below the age of 5. And then the patients keep growing, right? And the seizures also evolve. As before it was myoclonic, this could be also changed to atypical absence or focal seizures or focal with generalization, atonic seizures. And again, it could be still triggered by, as I say, heat, fever, but also visual patterns, photic stimulation, and arousals. And then the teenagers become status epilepticus and atypical absence are becoming less frequent. And then what happened in adulthood? So the status epilepticus and atypical absence may still occur, and they are less susceptible as a fever or heat, despite they are still sensitive to those. And then again, it could evolve to have seizure mainly during the night, be more tonic-clonic, nocturnal. So it evolves, but a clear history is essential to be able to diagnose properly Dravet syndrome. Other important features is the developmental, that it could be evident not at presentation of seizures, but between 1 to 2 years after the onset is when we can notice even more. There is a progressive deterioration, there is a speech delay, mild to severe intellectual disability, there is a developmental regression, there are some subtle pyramidal signs, there is a typical abnormal gait, the gait flexion characteristics, and then also behavioral disturbance in almost all of the patients, and it could be presented in different ways, from mood instability, short temper, autistic features, social difficulties, opposition behavior. So there is a clear spectrum of how the behavior will be, but is frequently or almost in all the cases. Other comorbidities beyond behavioral cognitive, it's also the respiratory infections, that they are relatively common. Even in a study that they count patients with Dravet admitted, 89% of those Dravets who were admitted, it was because of respiratory infection, and this decompensate seizures, and then there is like a complicated situation between treating the infection only, and the antibiotics may reduce the seizure threshold, and then all this complicated business that happens in neurology. And then, of course, injuries, and it could be from the trunk to the head, and that's very concerning because it can cause a severe intracranial bleed or fractures that it will directly impact even the seizures per se. As I mentioned, the cognitive disabilities, physical disabilities, very common, incontinence, and then this is all making the life of our patients a bit more complicated. So moving on to the second chapter, or the second age, is patients with childhood onset syndromes, and is between 2 and 12. And again, there are three main groups. They like to reclassify everything: the self-limited focal epilepsies, the generalized epileptic syndromes, and then again happens again the epileptic encephalopathy and development. And one of the cases that we'll discuss is the Lennox Gastaut. But if we go to the self-limited focal epilepsy, is 25% of all the childhood epilepsy, so it's a big portion of those patients. It's age-dependent and syndrome-specific at the onset. Usually they don't have a clear structural abnormality, normal examination, normal cognition. The perinatal and neonatal are unremarkable, and usually there is a remission that occurs around puberty and usually responds well to treatment. There is a genetic predisposition to abnormal EEG, and for example, some EEG findings are specific to some specific type, and also important compared to other types is the normal background. There are some genes, including green 2A, and they divide these self-limited focal epilepsies into groups. And the group 1, the self-limited epilepsy with autonomic seizures and self-limited with centrotemporal spikes, they usually have a better prognostic and self-limited. The group 2, with childhood onset occipital visual epilepsy, photosensitive occipital epilepsy, are usually good prognostic, but they will require treatment for the rest of the life. Moving to the other big chapter, generalized epileptic syndromes that start in childhood and include the childhood absence epilepsy, epilepsy with eye myoclonia, epilepsy with myoclonic absence. And then there is this group of epilepsy with myoclonic atonic seizures that it's included in the DE group. And this is because it's also myoclonic atonic seizure or DOS syndrome and represent 2% of all the childhood with seizures and usually start 2 to 6. But in this case, there is a regression of the development, cognitive development. It could be 24% of those patients have history of febrile seizures. 2/3 have normal development prior to the seizures, but then there is a regression. And the typical presentation is the myoclonic atonic seizures or generalized tonic-clonic. And the EEG will show this 2 to 6 Hz generalized spike wave. Usually it can present as a cluster, even a non-convulsive status epilepticus. 2/3 there will be a remission below the age of 3, but 1/3 of them will become drug resistant. And again, genes have been shown an association with DOS syndrome. However, because you have the gene doesn't mean that you are going to have this syndrome. And again, the CN1A is present again because it's relatively common in this population. So as I mentioned, one of the big group or big entity that needs to be discussed in this childhood developmental epileptic encephalopathies is Lennox-Gastaut syndrome. Is relatively rare, however, is common compared to other more atypical DEs or with a specific name. So the incidence is 0.1 to 0.28 every 100,000, so it's quite small, and it affects 1 to 2 of all the patients with epilepsy, and this increased to 2 over 100,000 in children's, and it affects 2 to 5 of all the childhood epilepsies. And there are two distinctions. One is with what we call symptomatic. We can find a lesion. It could be an hypoxic lesion. It could be a tuberous sclerosis that I mentioned later, but a big tuber or a big malformation of cortical development. But 30% of those patients is cryptogenic or unknown cause of that syndrome. A bit of the picture, the general picture usually start around 2 years, and they usually present in different type of seizures, and this is typical for them. It could be tonic, atypical absence, generalized tonic-clonic, tonic-clonic, tonic, myoclonic, so all the combinations that you want. But 95% of those patients will have intellectual disability, and this, of course, as I mentioned, was the disability, was the frequency of seizures, was the disability, was the disability, was the frequency of seizures. And on top of that, because of the type of seizures, the tonic seizures, frequently they have falls, and 50% of them. And this, of course, increase the risk of injuries and complications associated with that. It's not uncommon to recommend to use helmet in this population to minimize the injuries, or even in some cases, because the parents or the caregivers are so concerned, you just need to limit it. The deambulation will affect also for the progression or the capacity to be independent. And of course, there are different impairments as comorbidities, but also there are behavioral alterations. And then a big part of this is also the burden of the disease to the patient because of the seizures, because of the treatment, but also to the caregivers because they are always in panic mode because of the risk. They have a higher risk of dying. I will mention this later, but also indirectly because of the falls, they have a higher risk of injuries. And with all that, of course, the parents are very concerned and they adjust their lives around this situation. And remember that 75 to 95% of those patients will have cognitive impaired by 5 years since baseline. It's almost impossible, not completely impossible, because there is like a spectrum of Lennox-Gastaut to be living in the, because there is a spectrum, so there will be some that may be able to live independent with support, but the vast majority of them are fully dependent. As I say, some of them with wheelchairs or very limited mobility on top of that. So the triad of the Lennox-Gastaut is three main things: is the seizure type, the cognition, and the EG. The seizure type could be multiple types, and they are drug resistant. The most pathognomonic is tonic seizures, and they usually start below the age of 18. Cognition, all these patients have some degree of cognitive and behavioral deficits and may not be present when the seizure starts. The parents may say, my kid was normal until the seizure starts. And then final point is the EEG. There is a slow background and diffuse slow wave or spike waves. And it's common to see the rapid paroxysmal fast activity. But the interesting thing or the challenge that we face is this is the triad, the typical, but this is more common in kids. But when they get older, if I see a patient that may suspect Lennox-Gastaut, doesn't need to fulfill all these criteria, especially the EEG, or they don't tolerate to have a EEG, or the EEG doesn't show the typical findings at presentation. As I say, one of the typical type of seizures is the tonic seizures or drop attacks that affects around 50%. And usually it's this fall is preceded by a generalized myoclonic jerk, and then there's a tonic contraction of the axial muscles or axial atony, and then or both, and then it falls. It's quite common also to have a non-convulsive status epilepticus. 2 to 3/3 of these patients will have it. And also they can have different type of seizures, including atypical absence seizures that sometimes because of the behavioral problems, it's hard to identify one thing to the other. And generalized tonic-clonic seizures is usually presenting slightly later, but it's something to consider. And as I say, it can be the combination of all these type of seizures that we can see in the figure here on the right. So as I say, because the seizures change over time, at presentation, most of the patients have tonic seizures or myoclonic or atonic. But then if you see in later on with the evolution, we can see that there still is quite frequent, but still it can appear other types, including what we call nowadays more focal onset seizures, that you question how this patient can have focal onset seizures now when the EEG has been generalized all this time. So it's just to keep an eye when you start seeing the patients, because that will affect how the patient is presenting to you. The same thing with the EEG, the slow and disorganized background, again, is persistent, but doesn't mean that that could improve. The same thing with the slow spike waves or generalized paroxysmal fast activity that can be less commonly seen. And interestingly, what I'm seeing more is the solitary spikes. That is, as I say, it's as focal onset seizure is quite confusing why this is happening, but this is the evolution of this condition. The other finding is about the intellectual disability that, interestingly, they did a study in 2018 comparing patients with intellectual disability with Lennox-Gastaut who have like a etiology that we can identify, for example, like a perinatal stroke or a large focal cortical dysplasia. We saw, or they found that the abnormalities, the cognition or the behavior was moderately to severe intellectual disability in those ones with the structural compared to the unknown cause. And this was the opposite sides, patients with normal cognition, it was more commonly seen in patients that we don't identify the etiology. But doesn't mean that if you see someone with mild intellectual disability, that for sure this is going to be an unknown cause of their epilepsy. Moving to the next big group is the epileptic and developmental encephalopathies, or spywave activation in sleep. Again, there is a group of no DEs that I mentioned before, and the ones with DEs. And again, there is encephalopathy with continuous spike wave during sleep, Landau-Kleffner, and a typical benign focal epilepsies. Usually is less benign than some others, but is less severe than Lennox-Gastaut, for example. And the third big group that I wanted to review is the ones with variable age of onset. So it can be from newborns to in the 80s or 90s. So they divide this in different subgroups, like generalized epilepsy syndromes that I will mention briefly after this slide, that affects 15 to 20% of all the cases. Then we have also the focal syndromes that I will mention. And then we have also the combined focal and generalized, mainly with epilepsy and reading-induced seizures, but there are other entities. And also there are the epilepsy syndrome with developmental and epileptic encephalopathy or progressive neurological deterioration, which include febrile infection-related epilepsy syndromes, FIRES, that is relatively a new entity or newly diagnosed or discovered, compared to Rasmussen's syndrome, that is a classic. And then also we need to identify in this subgroup the progressive myoclonic epilepsy. So in these generalized epileptic syndromes includes different entities, including the idiopathic generalized epilepsy that usually are more benign, and I will mention after this slide. And then we have the other spectrum that could be developmental and epileptic encephalopathies, or could be an epileptic encephalopathy or a developmental encephalopathy. So in this group of the idiopathic generalized epilepsy that it represents a big portion, like 15 to 20, they usually have a favorable prognosis in terms of seizures, usually don't evolve to epileptic or developmental encephalopathy, but they can be drug resistant. So if you see a patient that has been labeled with idiopathic generalized epilepsy and is progressing, we are not in front of idiopathic generalized epilepsy. And then some of these syndromes overlap, like childhood absence epilepsy, juvenile absence, juvenile myoclonic epilepsy. And when they are not subtle in one syndrome, perhaps when they grow, whatever it was starting only in absence seizures, then could evolve with myoclonic seizures. So, and the fundamental findings is in the EEGs, the normal background, and then spike waves that they are not as low as the Lennox-Gastaut, and it could be also polyspikes discharges, and also hyperventilation and fatigue could trigger or worsen the findings in the EEG. The other big chapter that is inside this third group that can start in any age is the ones with progression, especially the progressive myoclonic epilepsy. The main thing is they could start as it looks like benign, but if you see a progression or deterioration of the cognition, you clearly need to reanalyze your diagnosis. And the same thing that progress with the comorbidities, but also with the seizures. If there is a progression of myoclonus, myoclonic, or generalized tonic-clonic seizure, there must be something that needs to be reassessed. And the same thing we can see in the EEG that start as a normal background, as we see in the idiopathic generalized epilepsies. If we see that becomes slower and slower, or the abnormal interictal pattern have been increasing, perhaps we need to discuss what we are dealing with. The focal epilepsy syndromes that can start in any age. Again, here in the table in the right side, you can see syndromes that we can see in different categories. For example, the DEP-DC5 that you can see in almost all the syndromes. It's just because, again, it's not specific for one. We have, for example, the sleep hypermotor epilepsy that characterized by this aggressive or brief hyperkinetic movements that it could be confused with functional neurological disorder, behavioral, but then once you see, especially with AEG, is very typical. We have also the familiar mesial temporal of epilepsy, that is several members of the family with similar presentation with what it looks like mesial temporal. There is the other type as familial foci epilepsy with variable foci, that is multiple members of the family, each one with different foci of the epilepsy. And it's not uncommon that we are seeing more and more often with DEP DC5. And then the epilepsy with auditory phenomena, that again is mainly characterized by these sensory triggers for our patients with focal seizures. Again, it's not uncommon to have focal cortical dysplasias, but doesn't need to be in the MRI in all the cases. And then the third big syndrome that I wanted to mention is the tuberous sclerosis complex. Again, these three syndromes are not that common. However, when you see many patients with epilepsy and with drug resistant, they will come relatively recurrent to your clinic. So the TAC may be different by the age, depends if they start earlier, perhaps the prognosis is worse than if they come when they are in the 40s or 50s. The seizures affects, or epilepsy affects 85% of those patients. And the other big thing to understand in tuberous sclerosis is TAN, or tuberous sclerosis associated neurodevelopmental disorder, that has been formally defined in the last few years, or in the last 5-10 years, and affects 90% of those patients. But to understand a bit of the physiopathology of the tuberous sclerosis, we need to understand the TAC1 codes for the amartin, TAC2 for the tuberin, and these are related with the mTOR pathway. And when this mTOR is not inhibited enough, what happens is that there is a abnormal growth and division of cells, which cause the creation of tumor formations. And these tumors, or what we call tubers in the brain, they are directly related of some of the problems that we see in patients with tuberous sclerosis. Again, the incidence is low, 1 every 5,800 to 1 every 10,000, and the prevalence is 1 in 200,000, sorry, in 20,000. 85 to 90% of the patients will have one of these mutations in TAC1 or TAC2, and TAC2 is slightly more common than TAC1. 30% they have an autosomal dominant inheritance, and 70% is sporadic. And between 10 to 50% of these patients with tuberous sclerosis, we cannot find a mutation. We have the syndrome without the mutation. And then the other relevant part in this group is also the mortality rate that is significantly higher than in the rest of the population. And this is likely related to kidney injuries, sudden unexpected death in epilepsy, and other comorbidities, including infections. So there are multisystemic involvement. I'm not going to go over that, but from tubers and focal cortical dysplasia in the brain, SEGAs, and also this could be associated with obstructive hydrocephalus. And then there is cardiac, pulmonary, renal, dermatological, almost every organ can be affected. 88% of patients will have epilepsy. The most common ones are focal seizure, 82%, and 65% of those patients will be drug-resistant epilepsy. As I mentioned, TAN is a very heavy comorbidity that needs to be treated accordingly. Sometimes it's even worse for the parents than even the seizures, and there are different levels from behavioral, psychiatric, academic, psychosocial. It's all affected, and it dramatically impacts the patient's life and the family. In a study published in 2017, they see that almost overreactivity was seen in 20% of them, impulsivity almost 20%, autism spectrum in 20%, and moderate to profound intellectual disability in over 26%. So it's something but very remarkable that needs to be identified and treated. Again, I'm not going to go over the criteria, just to mention that because if you have the genes, you have the definite diagnosis. But if you don't have the genes, but you have two major features, or one major and two or more minor, you are also defined. So moving to next part is like what we do with these patients. First is understand the risk factors and prognosis. As I say, early onset worse prognosis, high frequency worse prognosis, drug resistant worse prognosis, also structural metabolic worse prognosis, abnormal EG, regression of decline worse, comorbidities worse, some genetic or channelopathies, worse prognosis, sleep disturbance, worse prognostic, and of course, if there is some family history or epileptic encephalopathies, worse prognostic. This is just to be aware what we are treating and try to figure out what is the best approach for these patients. The other important thing is these patients can die because of the seizures, as in the entity called sudden unexpected death in epilepsy. And just mention that if we can see here, patients general population with epilepsy is 1.2 over 1,000 people per year. But if you see patients with intellectual disability, it goes 3.5, and patients who are candidates for more invasive or more aggressive treatment is 6.2. So if we talk about the syndromes that I just mentioned, you can see the mortality risk is significantly higher in both groups, especially the first two because of the severity, and this is a spectrum. It could be very mild or very severe. The cause of death from status epilepticus, sudden unexpected in epilepsy, and in tuberous sclerosis, other. Almost all are drug resistant. Again, tuberous sclerosis depends on the spectrum, and the prognostic overall is poor, and all of them are drug resistant, or 99.9% are drug resistant, at least in these two groups. So what can we do with these patients? So these are some examples of some syndromes that tend to be drug resistant, but the first is to introduce the concept of drug-resistant epilepsy. So we call refractory epilepsy is when they fail at least two anti-seizure medications that they are selected and treated for in the patients for enough time. And in general population, around 30%, but as you can see in Dravet or in Lennox Gastaut, almost all the patients will be drug-resistant. So drug resistance is relevant to be aware because, as I say, increase the risk of dying, but also status epilepticus, polytherapy, seizure complications associated with the treatment, but also the seizures. They frequently come to emergency, they require hospitalization, and the direct healthcare costs, but also the indirect healthcare costs, like parents are being out of work because they need to take the kids to the appointments, or they just need to be looking after the kids all the time. And this is important. At some point, we always want to be making the patient seizure free, but we understand the limitations and how severe are these epilepsies. So we want to limit the complications of the disease and the treatment, but overall we want to make a difference in their quality of life. And it's always discussing with the parents or the caregivers how much you want medication, how much we are affecting if the patient is sleeping all the time. So we, as you probably know, we have a long list of anti-seizure medications that we have been trying always to find new, but again, we haven't seen any big changes, and again, there is no specific medications for these syndromes. There are some guidelines that recommend some specific treatment that you should try, but doesn't mean that this is going to respond, and at the end, we just need to try whatever it works for each patient. The other thing is, of course, if the things are not going well, we need to do something. And of course, we need to reassess or diagnosis. And we can go from basic things, start with the EEG. If the EEG we see a progression, perhaps that's not ideal. We need to maybe reimagine the patients because perhaps, especially with babies, the demyelinization is not finished and it needs to do it later on every 6 months, for example, in some cases, just to confirm that there is no lesion, or once in a while, just to see if anything has changed, or the technology is better, just to see if we can see something. And the same thing with genetics. It's important to assess, especially patients with intellectual disability and drug-resistant epilepsy. They deserve to be tested if we don't have a specific cause, like perinatal hypoxia or something in particular, because they deserve to have a proper diagnosis. And in other cases like metabolic testing or even neuropsychology or clinical psychology assessment just to see if we are suspecting a decline, how is the patient declining. And again, bringing to the epilepsy monitoring unit is essential, especially in these patients with intellectual disability, because some of them, the parents are not sure if they are dealing with what we call conversive seizures or functional neurological disorder. Also, to see the label is we are treating focal, generalized, the mix. Also, sleep disorders versus epileptic, as I say, behavioral, side effect of medication. Also, to understand how often the seizures are happening and how disabled they are. Sometimes we bring them just to see if the treatment that we offer make a difference or not. And also to offer in patients with drug resistant, what we call a pre-surgical evaluation to see what else can we do to manage the epilepsies. So when we have patients with drug-resistant epilepsy, we know that the most effective treatment is resective surgery. However, not all the patients are candidate for resective surgery, especially in the groups that I just mentioned. But for them, we need to be able to identify a small focus where the seizure originated, and that focus will not overlap with eloquent cortex. If we fulfill these criteria, we can have 60 or 70% in the best cases of seizure freedom, and that's very remarkable. But if we go to the other side, frequently, especially in this group of patients with syndromes, we have bilateral or multifocal. It may overlap with eloquent cortex, or in some cases, despite all the tests, we are not able to find a focus. In those cases, we need to think about other strategies, including palliative surgery, that it could treat, for example, corpus callosotomy, some specific type of seizures, but not all. But it perhaps will improve the quality of life. Neuromodulation therapy like vagus nerve stimulation, deep brain stimulation, responsive neurostimulation, ketogenic diet, or trials with experimental anti-seizure drugs that the market is growing and changing, and that's always positive for our patients to offer something else. So one of the new drugs that we have in our market is the CBD or Epidiolex that is not that new, but it's newer to our practice here in Canada. And the mechanism of action is multiple and is still unclear. It can affect the ion channels through the sodium, but calcium. Also affects also the reduction of glutamatergic release, producing a stabilizing effect. Also indirect modulation of the endocannabinoid system. Also, it suggests some anti-inflammatory or neuroprotective effects. It was approved in 2018 by the FDA, in 2019 for the European Union, and currently the indications are Dravet, Lennox, and tuberous sclerosis. Again, some cases with what we can call developmental epileptic encephalopathies, despite doesn't fulfill the label of Lennox Gastaut, could be also indicated. Things that we need to consider is the side effects. Over 10% may develop some type of side effects. Like most of the cases increase when we increase the doses. From elevation of liver enzymes, diarrhea, somnolence, nausea, are the most common ones that we just need to be aware. And then the other drug that I wanted to mention is cenobamate. It's a double mechanism of action, including an allosteric modulator of the GABA, and there is also associated voltage sodium channels. Is approved for focal drug resistant epilepsy, and interestingly, we use the half-life is 50 to 60 hours, and the concentration is between 0.75 and 4 hours, and at single dose, but given at bedtime. And again, in this new medication has been extremely effective in many patients. The problem is some of the side effects, but adjusting the other medications, you can have a very good results, and it's something that you will see more and more in patients with epilepsy. But again, we need to remember that these patients are not only seizures, and despite that epilepsy is very debilitating phenomena, increase the mortality and morbidity, we need to think beyond the seizures, and the neurodevelopmental, the cognitive, psychological, and behavioral disorders, as well as the burden of the family, are very relevant to our patients, and all that needs to have like a multidisciplinary follow-up and care to make sure that those other comorbidities are under control. Um, Ideally, we should avoid losing the patients, especially in the transition age. That's the reason we develop our transition clinic, especially for the DEs. We should also minimize the emergency department visit with an emergency plan at home to explain to parents or caregivers what we should be doing instead to bring into emergency, because there is frustration. No one really solves that much in emergency, and it's kind of a waste without helping them, except of course when the situation requires. And then, as I mentioned, the relieve the caregiver burnout, because if the caregiver is burnout, the patient will receive worse care. And then, of course, we need to adapt to the social environment and promote as much as we can the autonomy and the patients to be engaged with activities. So, just to summarize all this information that I shared, I want to say that, of course, understanding some of these syndromes will improve the management of our patients. Again, many of these syndromes with childhood onset will continue in adulthood, and we need to be aware. As I say, the example of syndromes are relatively common despite their rare: Dravet, Lennox, Gastaut, tuberous sclerosis. Epileptic syndromes are frequently associated with drug resistance and require a referral and appropriate evaluation. And then the purpose of treatment is not just make them seizure free, that in some cases will not even be possible, but also to improve the quality of life and minimize the risk of dying, including SUDEP. There are more and more medications and treatment, including neuromodulation, that I didn't talk too much today, but this hopefully all together could help our patients. And again, think about the comorbidities of the patients and the burden of the families, because that's essential to be also addressed during our appointments or be referred to the appropriate specialist. So with all of that, thank you for your attention, and I'm happy to take any question.
So thank you. And so that was a fantastic review and well, education for me, and I assume everybody else as well. So we have a fair bit of time for questions and comments. If people would like to ask questions, it'd be better to do it if possible by a microphone. So if people want to raise their hand, that'd be fantastic. Otherwise, if people insist upon it, they can use the chat or the Q&A. Maybe I'll start though. And I mean, I see with CBD oil, does it? I mean, first of all, my own opinion is it's sort of seen as the treatment for everything that ails humanity nowadays.
Yeah.
And there's, at least in mental health, there's very little evidence that it makes a difference to anything in good studies. But is it thought to be helpful for anybody with treatment-resistant epilepsy, or just with tuberous sclerosis and things? Or sorry, with the Dravet syndrome, I mean.
Right now it's only approved, like, because of course there is the medical marijuana that everyone can buy in different places,
Yep.
and then there is the Epidiolex. And then I always try to, before we have Epidiolex, I say some of these products, one batch to the next, are not the same concentration, and it's very hard because they are not well controlled. But if we talk about the Epidiolex, that is the refined CBD oil, we use only for, as I say, with these developmental epileptic encephalopathies, despite that there is no evidence or no clinical trials proven that it's helpful with focal seizures per se. What we see when the patients explain to me about for example, focal epilepsy, and they use CBD oil or whatever, they calm them, they reduce the anxiety, they help them to sleep. And of course, anxiety, stress triggers seizures. So it's indirectly you are treating seizures, but not per se. So nowadays, we only prescribe for, as I said, Dravet, tuberous sclerosis, and Lennox-Gastaut. And I have seen in my patients that it responds. Again, it's not magical. They are not seizure free, but some of these, they have cluster of seizures. They may, instead to have it one cluster per month, they may have one cluster every 2 months. And that's half of what they were having before. So it's worth it, but not for everything.
Because I've seen some patients with I think, resistant epilepsy who have been put on a CBD or a PDLX by somebody. I'm not sure it was a neurologist necessarily, even though they don't have Dravet syndrome or tuberous sclerosis or something like that. So, I mean, are people using it more widely?
So because of the coverage,
Yep.
so they will need to pay for that. And currently in Ontario, it's only approved for if it's a DE, like developmental epileptic encephalopathy, despite not being in one of these three categories, we can figure out. But if it's not a DE, I usually don't think that, at least with the evidence that we have right now, that the things may change, right? But right now,
Yep.
I will not prescribe.
Yeah, it seems like, because again, I think it's used a lot in psychiatry, or by a lot of parents. And I think when I say parents that I know have used it for behavioral reasons. Generally, only like one or two have taken it for more than a couple of months. But I think your point though is really well taken about the fact that if they go and buy it at a dispensary or whatever, you're not getting the exact same concentration every time and things like that. Whereas I assume with a Pedialyte, it's the exact same every single time.
And the other thing is about the prescription or the concentration, right? The target dose will be 5 milligrams per kilogram to 20. Usually 20, 10 it's a good dose, 10 milligrams per kilogram. And of course, if you buy in a CBD store or a marijuana store, that's extremely expensive. So what was happening before, the parents were using CBD, but 1 ml, and that was like water.
Yep.
So
Yeah, I think that happens a fair bit, especially with something that they're not going to get insurance for. All right, Dr. Goldberg, great to see you, Ben. I will allow you to talk if you could just unmute yourself.
Okay, can you hear me?
yes.
Very well. Yep.
First of all, I was extremely impressed since my day, with the advances that have happened uh, in epilepsy. My day goes back to Dr. John Gervin and Warren Bloom.
Wow.
And so I just want to mention that the taxonomy that you've given is way ahead of where we were. The genetic sort of associations is way advanced, and the multiple anticonvulsant drugs is way advanced. But the one thing that was very impressive is Gervin and Bloom really developed the epilepsy unit. And I can recall one particular memorable case. There was a young man who was about 14 or 15. He was extremely aggressive with epilepsy, so aggressive that he was in seclusion most of the time. Out of seclusion, he would have explosive outbursts. And he had a epilepsy that was sort of essentially untreatable. And we referred him to I guess, the beginning of that epilepsy unit. Dr. John Gervin said what he needs, and we can give him, is a callosotomy. And so we had the callosotomy. This was the first and only patient that I recall. And lo and behold, the seizures disappeared. That was one of the things that I interviewed this young man. Is there any wish that you would have? I wish I didn't have seizures. And so it was essentially a miracle that the callosotomy worked. The unfortunate end to that incident, after he was discharged, he was walking on the sidewalk and was killed accidentally. So it
Wow.
was a very memorable thing. But I think the pioneer work of Bloom and Gervin, and we were fortunate to have um, um, George Hinton, who was our neurologist, and every developmentally handicapped individual had an EEG automatically, and also with phonic stimulation. But so it was assumed that if you were developmentally handicapped, you had a high incidence of epilepsy. But I'm so impressed with the advances that have happened, and particularly knowing about your work with neuromodulation. Um, and I guess neuromodulation can't be used uh, uh, very indiscriminately. I understand it's very difficult. And the kind of patients that you would use, or
Yeah, like that's I didn't talk about that because that's a big chapter that I love to talk, but I always talk about neuromodulation, so I didn't want to go there. So thank you for your comments. And again, we are very lucky to have the epilepsy program that we have, and it's all thank you to Dr. Gervin and Dr. Bloom because they did a fantastic job putting things together. They were pioneers and advancing all Canada, as it was the second center in all Canada in epilepsy. And then, of course, I think the message that you say is like we just need to see the patient, identify, be referred to the right place, and we will see what can we do for those patients instead to just wait and see. So again, some of these therapies could change life, as you mentioned, to your patient. Neuromodulation, again, in the past was also reserved for some specific patients because there was less evidence, but now we are being more proactive, and even patients, like even this afternoon, I saw a patient that is very delayed, very impaired, but we decided to, because he was implanted first with a VNS, didn't respond, and we implant to a deep brain stimulation. And despite we are not seeing like the patient is talking, but the parents are seeing that he's more engaged. The parents are seeing that he needs less rescue medications, that we are trying to reduce medication. And that is all worth it. And again, of course, we are lucky because our health system is allowing us to put these treatments. But again, we need to listen to these families that they need help, and why not to try? So deep brain stimulation or vagus nerve stimulation are good strategies for selected cases, but could change lives. So something to keep in mind too. But thank you for your comments. It was.
Thank you.
All right, Professor Dr. Martinez Trujillo, welcome. And if you could just unmute yourself, Julio.
Thank you for the professor, doctor. Anna, that's a fantastic thought. Thank you so much. I wanted to ask you if you could expand a little bit on the link between autism spectrum disorders and epilepsy, excluding TSC, of course. For example, the typical child with ASD that comes to see Rob or to see other psychiatrists, we know that there is certain degree of comorbidity. If there any association that you have, is there any clue on the medication that you use in those cases that gives you an idea of how these two things are related? I wish that would be, for example, we know that amygdala volumes are different in children with ASD, and we know that amygdala is a very epileptogenic structure, at least in animal models, and also in humans. Can you expand a little bit on that association?
So that's a very good question about, because again, sometimes first when they show up to our clinic and they are referred by family doctors or somewhere else, sometimes they mislabel cases about autistic or other things. And the first is reassure that what we are dealing is a true autistic. The second, I think it's I cannot give you numbers, but there is a clear association with some behavioral, especially with early onset epilepsies. Late onset are less common to have some of those problems. And electrophysiologically, we haven't been looking directly. Imagine if we put electrodes, as we put inside the brain, if we see if there is a difference in patients who have some comorbidities like autism spectrum or hyperactivity or whatever, if there are some different brain patterns. We don't have that information. And the other thing is about syndromes. Perhaps some of these patients, it's become like it's a packet that the epilepsy is triggering some of abnormalities, and maybe one of the presentation it's also the autism. Regarding medications, it's hard to know because again, these medications we give systemically and affects all the connections. So again, how much that's going to cost. In general, most of these patients is kind of coming already with the autism, no are making worse with the medication, and especially with the newer generation, they have less side effects that we should be concerned. But it's an area that needs further investigation, and again, from neurophysiology to, as you mentioned, neuroimaging detail could be all helpful to understand better.
Thank you.
All right. Oh, that's from Dr. Wittes at the in the chat. Um, you know, if I can, Anna, so do we know why do people with intellectual disabilities have a higher rate of epilepsy and perhaps treatment-resistant epilepsy also?
The what? Red.
Why do people with intellectual disabilities have? Is it just that their brains are, I don't want to say worse, but worse to begin with, or is there some other reason, do you think?
I think it's again, I think with genetics perhaps, and some of these cases you would like to see the tissue analysis of some of those areas to see how they react, how the communication is happening in at the neuron level. Um, it's in adults, for example, I don't know if I have any Rett syndrome, but in children it's very common to with the combination of both entities, epilepsy and Rett syndrome. So,
And the same as Julio was asking about with autism and things. And so what is it about, yeah, these groups of people? And it may be, as you said, there's common genetic factors or something like that.
yeah, I think it's, as I say, we are just starting again the genetics and more detail, pay more attention to those patients and how it's related. Also, you know this better than me, but in the past we were originally neurology and psychiatry were together, and then we separate. And I think more and more we understand that we need to be again together because there are so many interrelation and so many things that perhaps in psychiatry is related with neurophysiology that we were not fully aware before. So again, the interest is growing in that sense, and also how some medications like lamotrigine or valproic acid, that we use the same medications almost all the time, so it must be helping both ways because something it's also abnormal in that circuit. So I think in the next, I hope 10 years this explodes and we can provide better answer and better care to our patients.
Yeah, I think that point is really an excellent one. And I remember when I was in medical school, somebody told me that psychiatry was just undiscovered neurology. And I think there's probably something to that, right? We just don't have the same level of pathology to find. But obviously, we're dealing with the brain, and we can call mental health problems psychiatric, but at some level, it's got to be neurological because it's the brain that controls all these things.
Yeah, but let's see.
Well,
Let's see.
but and I appreciate this, and I thought it was a great talk, and we heard that comment from others. And what I personally really appreciate, Anna and I were talking a bit before the talk, and she was talking about how, part of her interest in people with intellectual disabilities is just the fact they tend to get underserved and don't get the greatest care. And so I think I think that's recognized and really appreciated by a lot of people in the community. So thank you for everything you do, Anna.
Yeah, no, my pleasure. Yeah,
Yep.
happy to be here. And anyone has any questions, just email me. Happy to deal with that.
Fantastic. So if I could just so on April the 16th, we have our annual continuing professional development afternoon at the Ivy Spencer Lodge, I believe, and we still have 10 places. It includes lunch. If anybody's interested, it can get information on our website, which is ddp.uwo.ca. And then our next round is going to be on May 13th. Gemma Graziosi, who is a graduate student in the School of Education, who's in the Applied Behavioral Analysis program, will be presenting some of her research on the impact of autism on families in Ontario, including the economic impact, but also the family impact of autism and things like that. So hopefully we'll see everybody on May the 13th. And Anna, thank you again for everything. It was great.
My pleasure.
Hasta luego.
Bye. Adios.
Take care.
Bye.